Hello, everybody, and welcome to today's webinar on neuropsychiatry, neuropsychology, and living well with Parkinson's. I'm Polly Dawkins, Executive Director of the Davis Phinney Foundation, and we are all so glad that you are here as our audience, as well as our wonderful panelists who will introduce themselves here shortly. Before we get into introductions and into the meat of today's conversation, I want to shout out and thank our sponsors of today's webinar. Amneal is a peak partner, and also CND Life Sciences has sponsored this particular webinar. Thank you to both organizations. So now, without further ado, I would like to introduce our two famous and fantastic panelists, Dr. Joanne Hamilton and Dr. Greg Pontone. I'd like to start by asking Dr. Hamilton, Joanne, if I may, to introduce yourself and tell a little bit about who you are and why we might have invited you, besides the fact that you're awesome.
Thank you, Polly. And I have to say hi to all of you from the national and international space I'm watching pop up here from Belgium and Canada and Ireland, as well as all across the U.S. That's really exciting to me. I have been involved with the Davis Phinney Foundation for almost 15 years now, I think, maybe a little bit longer. I am originally an academic neuropsychologist. I trained at the University of California, San Diego at their Alzheimer's Disease Research Center. And I was the recipient of National Institutes of Health R01 that studied cognitive and behavioral changes in the Parkinson's spectrum disorders, including dementia with Lewy bodies and Parkinson's disease. Around 2013-ish, I decided to move into the clinical spectrum because I first of all, I got really tired of writing grants and manuscripts. And second of all, I really started to feel like there was a space for me to translate science for people who might not have access to that science in other ways. And that has turned out to be a really fulfilling part of my life. And so I spend most of my days working with people who have any variety of neurological disorders. And then I get to do these things from time to time and visit with you all. So I'm very excited to be here and very, very fortunate to be a part of this group.
Well, thank you, Joanne. And Dr. Greg Pontone, welcome.
Hi, I'm Greg Pontone, and I'm a neuropsychiatrist. I did my training at Johns Hopkins back in the early 2000s, and then most of my early career was doing research with people with Parkinson's disease, and specifically focusing on the non-motor symptoms. In 2023, I moved to the University of Florida, in large part because Michael Oken has a large footprint in helping people and promised me that we could have a bigger reach if we worked together. And he's been absolutely right. I feel like we're reaching more people now through, the efforts we have here. And like Joanne said, I unfortunately still live that life of midnight grant writing and, seeing patients when I'm awake. And part of the reason I think people are willing to kind of suffer that way for at least part of their career, I don't know how long we can keep it up, but is that it's the best way to translate what you see people dealing with in the clinic to real world solutions. And that's really what our work has been based on is, having a research project that can bring things as soon as possible to the people who are dealing with the disease. And that's the work that, we continue to do, despite the challenges, in the new research environment. But I think there's reason to be hopeful, where everybody's still finding funding. We still have many, if not more, projects in Parkinson's than we did earlier in my career. More people are fighting this fight. More people are looking for answers in new and creative ways. And so I absolutely have seen significant change in the 2 decades that, we've been at this.
Thank you. So let's start with you, Joanne. What is the focus of a neuropsychologist, and why might somebody come to see you?
Oh, for sure. So neuropsychologists bridge the psychological world and the neurological world. So we hold specialty training in understanding how diseases of the brain affect a person's behavior. We interface really closely with our psychiatrists and our neurologists because part of what our job really is to try to tease apart the aspects of a person's behavior, their cognition, their thinking, their mood, their reaction to situations. Try to tease apart how much of that is neurologically based, meaning the structure, the neurochemical aspect of a person's behavior, versus situationally based, the impact of a disease on a person's well-being. The impact of a disease or a condition on a person's marriage, job, stress levels. And in so doing, we then help our medical colleagues try to put together something of a treatment plan that takes into consideration all of those factors.
Terrific. Thank you. And Greg, tell us about the focus of neuropsychiatry and why might somebody see you?
Yeah, so, I think really the tipping point is when you notice that mental changes are causing things to not work right. So you either see maladaptive functioning or frank dysfunction. So something that you previously were able to do and can't do anymore, and it's not because of a physical disability. And I think part of the thing that's changing now that is an artifact of the way we approach things in the past is that it's more than just cognition. These diseases change behavior, the way we process our moods, the way we're motivated to do the things we normally enjoy. And when we look at it that way, it explains a lot of the disability and diseases like Parkinson's, even though we think of Parkinson's as a movement disorder. And so, really, this is a broader net than people realize. You don't want to wait until you're, depressed to see a neuropsychiatrist or a neuropsychologist. They probably belong much earlier in the disease course.
It's a good point. And that leads me to the question, let's talk a little bit about what mood and emotional symptoms we might see in Parkinson's, and how can each one of you help with those things? What are we looking for when we start to think, oh, we should probably see somebody?
Well, I'll start. So we know that depression, low mood, loss of interest in activities that used to be really exciting for a person, and anxiety, so that kind of agitated, restless, worry, those are features that can start years before a motor symptom of Parkinson's. And they're very, very common. Probably at least 40% of people will experience some degree of mood and anxiety change before the motor symptoms. And Dr. Pontone made a really great point there, that even though Parkinson's is a movement disorder, those of us in this field are starting to see more emphasis put on those non-motor symptoms, which probably cause more disability, frankly. And unfortunately, early in both of our careers, we started out at about the same time. Neurology did not recognize the impact of these non-motor symptoms, and in fact, thought they were, just, I don't even know what they thought they were. They didn't matter, apparently. We know that for patients, they are incredibly important. And so oftentimes, one of the first reasons for referral is a person will have some vague motor symptoms, but really be struggling with these mood issues, anxiety in a person who's never had it, or depression or lack of motivation in a person who's always been driven. And those are usually when I will start to see patients at an earlier stage.
Greg, any thoughts, any additions there?
Yeah, absolutely. One of the things that I think is sort of implicit in what we do, but not necessarily said out loud, is defining the scope of the problem, right? Because often these things are hidden or very subtle, right? If you have a physical problem, if you're limping, if you're falling, people can see that. you don't always recognize when a mental health issue is present, right? You know something's wrong, but a very common and unfortunate scenario in the case of depression and apathy is you'll blame the person or see it as a character flaw. I don't know why he's so lazy all of a sudden, or she used to be, a really a go-getter, and now she just sits on the couch. And so that is, in many cases, apathy or depression. These are biochemical changes related to the disease, and yet sometimes they're perceived as a failing of the patient, and that's one of the first things we have to take ownership of that and put it on the disease rather than the person. So that's part of our job, is to make people aware that this belongs to the disease and not the person who's suffering from the disease. And then the other is that we have to take the stigma from anything in the mental health realm, the psychiatric realm. It's if you have diabetes, people don't whisper about it, right? They say, well, he's got diabetes and he takes his insulin. But if you have a mental health issue, we whisper about it, and it's, it comes with another burden that, is problematic. And so I think putting it with the disease, something that people recognize, can help take some of the sting from that stigma that sometimes comes with these mental health issues.
I have to say here to that. I can't tell you how many caregivers, care providers, care partners that I speak with who are still harboring a good amount of resentment for changes that occurred 10, 15 years before a motor sign was elicited. And it's really helpful then to meet with someone like Greg or myself, who can then kind of bring you back and say, but this was just the first sign of the disease. At this point, Parkinson's is still the diagnosis, the diagnostic criteria are when the rigidity and tremor or bradykinesia start. But we know that years before, we were already starting to see those changes. And I think that helps. I think that helps families and an individual living with Parkinson's take a little bit of the guilt off of the changes that have occurred.
I'm reflecting on a podcast interview we did years ago with Dr. Maya Katz. And she was talking about some of these, depression and anxiety, and that people's approaches, they often say, well, just pull yourself up by the bootstraps, right? That's our approach too. You would never tell anybody with diabetes, just lower your blood sugar, like just do it naturally. And if you don't have the neurochemicals or transmitters that you need, you don't have the bootstraps to pull yourself up by. They don't exist.
Exactly.
I thought that was a powerful way of thinking about it. Yeah. In the conversation, somebody asked, how long does it typically take somebody to get in to see a specialist like yourselves?
Oh, that's a sad part of what our healthcare system has done. So unfortunately, I don't think that we were nimble and recognized that our aging population was going to have a lot more diseases of the aging, for the most part. And so it is hard to get in quickly to neuropsychiatry. There are very few, truthfully, neuropsychiatrists in our world. Even in San Diego, which is kind of a hotbed of neuroscience, we don't really have what I would consider like clinical neuropsychiatrists. So it could take months, frankly, to get in to see a neuropsychologist or a neuropsychiatrist. That doesn't mean you don't try. And I saw that the chat showed up with a group of a link to neuropsychology. I don't know, Greg, do you have a nice way of finding neuropsychiatry?
No, not good enough. That's for sure.
So if I've also seen the title, and maybe one of you hold the title of a neurogeriatric, I don't even know the term.
Neurogeriatrician?
Thank you. Tell us, does either one of you know that term and what that is and who that is?
Well, that would be a super subspecialist.
Okay.
So I think that most of us in the neuropsychology field would consider ourselves geriatric specialists. Obviously there are pediatric neuropsychologists who won't touch it with a 10-foot pole, in the same way that I would never see somebody who is young, younger than 18. We're just not trained. Those are two very separate things. But most neuropsychologists who are board certified or who have gone through formal training have had access to training in diseases of older people. And by older, I mean my age and up.
We've all hit that.
Well, I will say the issue of access is one that's not going to go away. And so we don't have near enough movement disorder specialists, neuropsychiatrists, neuropsychologists to keep up with the demand. And the good news is, though, that there are people in the Parkinson's community who are working on how to improve resources, even with this dearth of specialists. And so, for instance, my group just met in Washington last year with a legal firm that lobbies for changes in legislation called MANAT. And basically, we're looking for ways to expand services using infrastructure that's already available. So you can accelerate training of movement disorder and neuropsychiatrist specialists. You can do that, but it's still never going to meet the demand. So we've looked at things like, how can we use resources like physical therapy, occupational therapy, and speech therapists who have special training in Parkinson's? And the infrastructure for this exists in the Parkinson's community.
Let's dig into that a little bit more. So if you are somebody who's identifying that you really could use support from a professional, like a specialist like one of you, and you do find that it's quite a long wait, or you have to travel to find somebody, and that could take some time, what do you recommend, either of you, that somebody does if they're experiencing symptoms that are really troublesome, but they can't find somebody immediately? What does somebody do?
A couple things. So there's a couple of websites that can help a person identify psychologists who can help then at least begin treatment. And very often those psychologists recognize that they might need some additional support from a subspecialist like myself, right? So a psychologist can then contact one of us and say, hey, I've got a patient and this is some of the things that are going on. And we are more than happy to give kind of a background and some things to look for. San Diego's Parkinson's Association is training trainers to teach clinical psychologists more about these disease processes. I'll put in the chat, there's, I have found personally and for my patients, an excellent web-based platform. It's called the Balance app that teaches mindfulness-based stress reduction. And it's a super easy app to use, but it's very helpful, especially for those initial like anxiety and sleep disorders that occur early in Parkinson's. And that can be a bridge, at least to bring down the temperature a little bit before a person can get in to have a thorough consultation. And because, obviously medication may be necessary, but sometimes the medications that someone who's a generalist and doesn't understand Parkinson's will provide could actually cause more problems. And so it's nice to do some behavioral things first. I'll put a couple of these things into the website so that people can explore them.
Let's talk a little bit about some of these changes that you both are referring to. Let's start with cognitive changes and challenges that people are experiencing. Can you talk a little bit more about what are the cognitive challenges or changes that people may experience and how that happens, how you can manage it?
Mm-hmm. So oftentimes even a little bit before and certainly within the time frame of motor diagnosis of Parkinson's disease, the vast majority of people will tell you that they're experiencing what we call executive dysfunction, which is some problems with planning and problem solving and thinking flexibly and motivation. Those kinds of like higher order cognitive functions that guide the rest of your behavior. And those are occurring because the same neural circuits that are affected by neurochemical depletion that cause the motor problems are also driving cognitive issues. They all run in parallel through the same brain systems. And so those executive changes might start to cause problems at a person's job. You know, a lot of folks who are diagnosed with Parkinson's are still trying to work full time. It might make it difficult to balance two separate streams of information at the same time. It might make it difficult to recognize the importance of some tasks over another task. And so, you know, everything becomes overwhelming because everything is equally as dire, if you will. That executive dysfunction is typically fairly stable throughout the course of Parkinson's. Now that when we look at what types of cognitive changes predict the greatest disability, it's not really executive dysfunction that predicts the greatest disability. It's changes that often will occur later in the stages of Parkinson's disease. So right at the very beginning, we're already seeing that executive problem. So what to do about it? There are a number of ways to simplify life a little bit. And that's what I would really recommend. You know, you're thinking about when is your best time of the day to do tasks that are complicated, because Parkinson's tends to fluctuate. There are going to be times of the day that you're crystal clear and other times of the day where you're very cloudy. So what's the best time for you? You're going to want to try to do one task at a time, which I know is really hard, but start something, finish it. Because if you get interrupted in the middle, it's very likely that you won't really remember where you left off, and then everything feels ineffective. And try as best you can to remind people that distraction is not your friend. And so if you're in the middle of something and you're constantly being distracted, there's a good chance you're never going to get that done. So, you know, those are some things. There's a website I just hit send, and it's called CogSmart. It was developed by one of my colleagues at the VA. And it's a manualized cognitive retraining program, but it's free. She's wonderful. And so she just put this manual online. You just have to sign up and tell who you are, and then the manual will come to you. And it's just great techniques. Frankly, all of us could use it. But some of us are stubborn and just refuse. But it's something that I would recommend.
Thanks. Greg, anything you'd add to that part of the conversation?
Yeah, no, it's a real challenge. I mean, as Dr. Hamilton said, at the time of diagnosis with Parkinson's, up to 40% of people will already have cognitive changes. And the majority of these fly under the radar, meaning that nobody's aware of them. And we don't necessarily test everyone. You know, in some research studies, we pick this up, and that's how we know it's as high as it is. And so the first thing that we do is we try to orient people to what's normal aging, you know, what cognitive changes you can expect with aging versus what should raise a flag that maybe something else is going on, whether it's related to Parkinson's or a medication or some other change, because that's where we need to intervene and make a change. And, you know, a lot of this is just reassuring. So when you get people who are in their sixth decade or more, not remembering names or struggling to, oh, hey, what was my third niece's, you know, exactly. You know, as weird as it sounds, but it comes to you, right? That's normal. That happens to most of us. But there's other things that really shouldn't be changing at least into your 80s, right? And so those should raise a flag. But even then, you know, so she talked about executive dysfunction. What does that look like in day-to-day life? You know, we can describe it as trouble with planning and organizing and what we call set shifting, you know, going from one activity to another. And here's the things that I hear from my patients all the time. If they're still working, they can still more or less do everything they always did, But if they're distracted, they lose their place. If there's multiple conversations going on, they can't keep up, right? Everything takes longer because when they transition from one activity to another across their workday, there's an inflated cost of cognitive effort. That's what we call set shifting and executive function. So you don't necessarily name all these things, but they're part of what she just described. And then the other one is, even if you're not working, people will tell me, hey, I'm walking in a group, and if I'm talking, I fall behind the group. Whereas if I don't talk, I can keep up. And that's a classic sort of gating, cognitive motor gating issue that is part of executive function. And so these little tells sound inconsequential by themselves, but they're what tells us that you're experiencing that type of change. And I think all the strategies, these aren't, very sophisticated things. They're things that all of us would benefit from, but people with Parkinson's will benefit even more, working on one thing at a time, minimizing distractions.
So you mentioned, Greg, red flags. Did I miss, or maybe you could repeat them if I missed them, somebody else?
Yeah. So
what are the red flags, and what would somebody do if they feel that they see those red flags?
Yeah. And the first thing I always like to qualify is whenever I'm going to talk about something scary is this does not happen to everyone with Parkinson's, right? In fact, it's a portion. But if you start to notice that your memory is more affected, that type of change usually signals something a little more than typical vanilla Parkinson's. Okay. And that's something you want to bring to the, awareness of your treatment team. Okay. It turns out that a certain proportion, certainly not everyone and not the majority of people with Parkinson's, are a little more at risk for Alzheimer's changes in their brain. And that is going to affect you cognitively more than garden variety Parkinson's. So that's one. The other is, for the most part, we don't expect Parkinson's to affect your language skills, both expressing yourself through language or being able to comprehend language. You might need people to slow down or talk one at a time, but your ability to comprehend and express yourself should not be affected. If it is, that usually merits additional testing to make sure that nothing like strokes or another process is present.
Thank you.
And let me add just real fast to the memory part, because I do want to underscore the fact that minor forgetfulness is common for all of us. What Greg's talking about is, and I always say this to folks, when you don't remember what you forget, that's the issue, right? So most of us who have forgotten, let's say that we're supposed to give a talk or something along those lines, right? The second we see a reminder of it, boing, of course, it's right back for us. But we have patients that will come in, and they're typically brought in by loved ones because they are not aware of the types of things they're forgetting anymore. That could be something else besides our typical Parkinson's.
Thank you. All right. Shifting away from cognition, unless there's anything else you'd like to dive into, or if we have anybody in the audience has a question about cognition, I was going to shift to some sleep issues. Does that work for both of you? Okay. So can you talk a little bit about why sleep is so important? Well, I think we know sleep is important, but why it gets affected by Parkinson's, and how somebody in your fields might be able to help somebody with sleep issues or sleep disruptions.
Yeah, there's, how to unpack sleep and Parkinson's. So, first of all, for all of us, sleep is one of the fundamental pillars of wellness and good health, right? If you don't sleep well, almost everything else is compromised to some degree, right? Sleep, the job of sleep is to restore our physiology, and that's both our body's physiology, but also our brain's physiology. Many people believe that's when memories are consolidated. So even someone with a healthy brain who has poor sleep remembers less well, right? The good news is, with these type of changes, they're all potentially fixable if we can improve sleep, right? So even in people with Parkinson's, if we fix their sleep, many things get better. And so the first thing to really focus on is something that's accessible to everyone. You don't need medicines or anything else, and that's having good sleep habits. Sometimes you'll hear this referred to as sleep hygiene. You can go on, I don't know, 100,000 websites and find good sleep hygiene recommendations. And the trick to any habit is doing it consistently over a period of time until it becomes automatic. And believe it or not, that's the heavy lifting. If you can get through about 60 days of good sleep habits, it'll become automatic and your body will become more efficient in sleeping. Doesn't mean your sleep will be perfect, but it will try to achieve its maximal efficiency. And so I always tell people, don't beat yourself up. If you have good habits, all your job is on that front end is giving yourself an 8-hour sleep opportunity. Now, whether you sleep the full 8 hours or 6 of it or 4 in the front and 3 at the back, you're maximizing your efficiency. Now, if you're still compromised, that's when seeing the physician and other specialists comes into play, right? Because Parkinson's predisposes you to having an airway that can collapse and not allow oxygen to flow. So we call that obstructive apnea. It also slightly increases your risk of what we call central apnea, which is other mechanisms that cut off the respiratory drive that oxygenates your brain overnight. And those can have all sorts of impact on your brain function and your heart function and everything else. And so, again, this is really usually a multi-step process of how to address this. And I always tell people while you're waiting for your appointment, start practicing good sleep habits and taking, a journal of, hey, my partner hears that I stop breathing in the middle of sleep, or my partner says I snore, or hey, 2 weeks ago I hit my partner and she laughed and said it looked like I was fighting someone in my sleep. All of these things are really important information to help your doctors make the appropriate referrals and tests to figure out where to go next.
So you mentioned setting aside 8 hours to sleep, even if you're not fully sleeping during that time. What about sleeping during the daytime? We hear people say they got excessive daytime sleepiness or so much fatigue that they're wanting to sleep during the days. Do either of you have a strategy or thoughts on that?
Well, part of the problem with Parkinson's is that it's a fluctuating course, right? So Parkinson's is very different, even frankly, than something like Alzheimer's, which is a fairly persistent cognitive disorder. You don't get the same up and down. And so folks with Parkinson's it's a chicken and the egg. Sometimes the Parkinson's is the cause of the excessive daytime sleepiness, and sometimes it's the effect of the daytime sleepiness. So I typically will recommend to my patients the sleep hygiene piece, but also the daytime hygiene piece, which is help a person get plenty of light, exercise throughout the day. I usually suggest a brief rest, even if it's not falling asleep, early afternoon, 30 minutes, set the alarm, 30 minutes, 45 minutes. That seems to give many of my patients enough of a recharge to make it through the rest of their day reasonably. Because part of the sleep hygiene is putting a bedtime that's consistent 7 days a week and a waking time that's consistent 7 days a week. And so many of my patients will get into trouble because they don't take that nap in the early afternoon, which makes them very sleepy and tired by 7 o'clock. They go to bed, but now their 8 hours is waking them up in the very, very early morning. And this starts to get a pretty bad cycle where we're going to bed either much earlier than we should, or we're going to bed much later than we should. So that's part of my thing, is make sure you're getting plenty of light and at the very least 30 minutes of walking a day.
Super. Great strategies. We've got a couple of questions in the audience. A couple of them relate to sleep issues and medications. Russell has just asked, what about frequent bad dreams, nightmares, disruptive dreams? Is that Parkinson's, or could that be medication caused?
Yeah, I guess what I'll say about that is anytime you're dreaming, you're entering what's called a REM state. right? A rapid eye movement sleep phase, which is one of the deeper phases of sleep. It's also a phase of sleep that we know is maybe one of the most important, because your body will prioritize that REM sleep over all others if you're sleep deprived. So oftentimes, if you fall asleep and go immediately into REM, that's a sure sign that you're REM sleep deprived, because it's putting you immediately into that deep phase of sleep. And anytime you see that, the first question you should have is, am I sleep deprived in general? Right? If you're dreaming more, right? There are certainly medicines that can make you have a lower arousal threshold so that you wake when dreaming more often and then you remember that you dreamt. But most of the time we dream at least 2 or 3 REM phases a night. We just don't remember them, right? So that should signal the fact that your awareness of a greater dream frequency should be a signal to go see somebody about whether your sleep is problematic. So sometimes people have undiagnosed sleep apnea, whether it's obstructive or central, right? Or have other factors that are, keeping them from normally transition from the light phases of sleep, like phase 1 to stage 2 to 3, 4, and then in and out of REM. And, that this can all be formally studied in sleep studies. And it's something we make regular clinical referrals for. And so if you notice that change, that's something to talk to your doctor about, because it may mean that your sleep needs to be evaluated.
And when you say speak with your doctor about this, which doctor, right? We have lots of different doctors taking care of us. Who do I talk to?
For the most part, it's been the purview of neurologists and psychiatrists and geriatric internal medicine doctors. But more and more, our primary doctors, they've taken on such a burden. They do everything now. So even a good primary care doctor can make the appropriate referral if you give them the good information. And I think this is the one thing that I think the internet has helped. My patients and I always have conversations and make jokes about Dr. Google. But the truth is, I think we've gained more from people being informed, from us as patients when we're on the other side being informed, than we've lost because of, lack of agency for the providers.
I've often heard about medications. Like, some people will just reach for a sleep medication. And I see Joanne's reaction immediately. What should we be careful about? What should we avoid? And why, when thinking that sleep medications are our friend, especially living with Parkinson's?
I'll just say, from the cognitive side of things, we are aware that medications with a high anticholinergic burden, which is diphenhydramine, the active ingredient in Benadryl, and almost every over-the-counter PM, causes, especially for an older adult, and especially for an adult who is already neurologically vulnerable, more confusion and more risk of balance problems. There's evidence that across your lifespan, the more of those types of medications that you have used, the higher your risk of all-cause major cognitive disorder will be. Obviously, there are, and these medications are in drugs you would never suspect. So there are heart drugs, there are antidepressants, there are drugs that you don't necessarily think might be part of your regimen. It's a conversation to have with your primary care doctor, because very often these are drugs that are being prescribed by a number of different specialists who are not necessarily aware of all of the conditions. And so from our standpoint, from psych standpoint, remember, psychologists in most states do not prescribe medications. It's our task to just educate an individual to talk with their physician about whether these drugs are necessary and if there's another alternative for those drugs, which is why when we talk about reaching for a sleep aid, I shake my head and just say, whoop, let's hold that for just 1 second.
Greg, anything you'd add there, or is that for...
Yeah, no, I think what she said is really important. So early in my career, that was a big issue. Majority of people with Parkinson's at some point will have trouble sleeping. And the first thing you reach for is that, brand name PM, whatever it is, and it's diphenhydramine, and you're going to lose more than you gain. Now, that doesn't mean that medications can't be effective. It's just you have to choose the right ones. And so, for instance, depending on the type of sleep problem you're having, so if you're having insomnia, the first thing we reach for now is melatonin. And it turns out that there's been formal studies of melatonin, including in Parkinson's, and it actually works for many people. Here's the one thing, though, where people sometimes bail out before it's had a good opportunity, is it's not a soporific. It doesn't necessarily make you tired and fall asleep. But what it does is it sort of greases the wheels of the sleep stages that I talked about. So it makes it easier for you to transition from light, stage 1 sleep to 2 to 3, and then all the way down to those restorative levels. So, when you take it, you want to take it an hour or two before you want to be asleep. And so I think melatonin probably would be better adopted if our communication about its appropriate use was better. And in terms of safety, it's got a wonderful safety record. So that's usually where we go first. It's also got some evidence in Parkinson's for helping with the REM sleep behavior disorder, where people thrash around and act out their dreams. And then, if melatonin fails, that's when we start going to the heavier strength prescription medications. And we have a range of those that don't work through the anticholinergic mechanisms that Dr. Hamilton mentioned, because those really, even if they work, you're in the long run, you're going to lose more than you gain.
So since we've touched on some medications and sleep, there's an interesting question that came in ahead of the webinar. And this person asked whether a medication change from one formulation of a medication to another formulation of the same medication can trigger non-motor symptoms like sudden and severe onset of things like depression, anxiety, apathy, or even insomnia. And this person said that happened to them. And they went to back to the old formulation, and those new symptoms, those new non-motor symptoms went away.
Mm-hmm.
Have you thought about that?
Routinely, yeah. Switching between formulations, we routinely hear not just changes in motor function, but reemergence of anxiety. But we also hear it the other way. I would say we have at least as many, if not more, where you switch formulations and you get a better result, both in terms of your movement and the other. So it can happen in both directions. So that's a great point.
This is the part I think that makes me saddest about our current medical system, right? Because in a perfect world, you would be prescribed a medication, and then you would have a follow-up within 2 weeks of changing that medication, a month within, to talk to your physician about the changes that occurred with that new formulation. And we don't have that. Many places your follow-up is 6 months from that point. And so I encourage everyone, most of our systems now, our medical systems now, allow at least a direct message to your physician. And at the very least, when you start a new drug, to send that direct message to the physician, their team will get it. And if the symptom is something that sometimes the physicians will just say, this is something that probably will wear off over the course of the next couple of weeks. The side effect is there more when we first start than it will be when it goes. Antidepressants are this way. At least they're aware, because that's the real key. People need to be, I think, more of an advocate for their own care than I wish we had to be. But it is the case. And if you don't tell anybody that you're having this new symptom, they won't know. And changes can be made.
Yeah, interesting. I heard 2 cases exactly like this week.
Mm-hmm.
And in both cases, both were very intelligent individuals and very involved in their own care and just didn't know. And it took weeks, if not a month, to figure it out. And, the follow-on question to that is, what if this is happening to you and you're experiencing, a deep depressive state or something that's really different for you, a non-motor symptom that's really different for you. And let's say it's in the middle of the night. What do you do? Who do you call? Who do you talk to? Who do you turn to? And maybe it's your care partner has noticed this. What does someone do?
Well, it's me, and it's a severe change, and it's a new symptom. I'm going to, at the very least, call the nurse helpline for my medical system.
Yeah, one of the things that I want to credit one of our former nurses, Becky Rye, she always would tell people there's no cliffs in Parkinson's, meaning that a sudden change means you need help now.
Yeah.
That is a perfect way of saying that. I'll tell people this is a progressive disease. It's progressive like this. It's not progressive like this. And anything that goes like this needs an urgent medical evaluation, because in a vulnerable brain, and this is for any brain that's vulnerable for any reason, but in a vulnerable brain, even non-Parkinson's related systemic changes, whether that be infection or new onset pain or urinary tract infection, can cause a change in behavior that's very acute. We shouldn't see that in Parkinson's. And if it's there, then it's very likely that it's something else that needs to be addressed.
Great point. We have a time for a few questions that are still lingering from the chat. Before I hop to that, is there anything, Joanne or Greg, that you were hoping we could touch on today that would be helpful for the whole audience?
What I will say is that Jim just put in a message about anticipatory anxiety, and we didn't talk a lot about anxiety. But I think that this is a really important topic because the lay public, those that are not living with Parkinson's or a neurological disease, think about anxiety as feeling stressed out about an event. And that can be anxiety. But for Parkinson's, anxiety is also very endogenous. It's driven by the disease itself. It's driven by the body's response to recognizing that there's something not working with the way that the chemicals are being emitted. And so anxiety in Parkinson's, I think, takes a beast or a mind of its own. It becomes a beast itself. And the question about anticipatory anxiety comes from that fluctuation in the amount of dopamine that's available. And the brain actually can start to detect that it's starting to slow down. And that causes more of a panic reaction. Panic doesn't necessarily have to come because a bear jumped out and is trying to eat you. Panic can also come when the physiological state of panic can come when the body recognizes that it's not functioning normally. So we can see panic disorders at a higher rate for women who tend to have a certain type of heart change or heart defect. We see panic disorders or anxiety disorders happening when someone has congestive heart failure and their brain recognizes that their heart is no longer pumping accurately. And we see it in Parkinson's. So that anticipatory anxiety, in my mind, is a discussion to have with your neurologist, because it may be that you've started to reach that point where dopaminergic replacement is not going to be sufficient for managing your disease. And that's a different conversation.
That's fascinating. Fascinating. We have time for one additional question, I think. And this one is a common question that we hear and we experience. And I'm going to try to summarize it. But person talking about problems with executive function, primarily somebody who's focusing on a thing, an issue, and can't let it go and can't consider alternatives. Any thoughts on what that might be and what might help?
I mean, it could be a number of different things. And so, there can be some decreased flexibility of thinking. So getting stuck on something could be the inability to set shift, right? To go from one thing to another. Sometimes it can be what we call perseveration, where you keep hitting the same topic or issue, and because you can't resolve it, you never get out of the loop. Oftentimes, this type of thought process can be driven by dopamine. So usually when dopamine peaks is when we see this. And when it's accompanied by a repetitive behavior, we often call that hunding or hobbyism. And we can see that very frequently in people with Parkinson's. There's other conditions too, but definitely in people with Parkinson's when their dopamine is at a high level or peaking.
And thoughts on how to help with that, since we all need the dopamine?
Yeah, well, usually we see this a bit more in people who are having cognitive changes along with the peaking dopamine. Sometimes we see it without it. So this is definitely something you'll have to untangle with the help of your doctor, because usually it's not just a matter of, hey, if I just reduce the dose or change the timing, it can take a little bit of work. Sometimes we'll actually support these people cognitively with a medication, and sometimes that can help. But there's nothing really proven. So it's usually an empirical process that's individual specific.
And I'll add to it that care partners at this point have to recognize that most likely is Parkinson's disease driven. This is not an individual now being inflexible or
Stubborn.
Personality inflexible. Exactly. Stubborn is the word I'm trying to go for. Thank you.
I'm a master of that.
And the word sounds like stuff. Yeah, this is not a personality flaw, if you will. This is the disease driving this. And sometimes the most helpful is to bring that person out of the situation that is initiating, or that is kind of getting them stuck into that loop. So, hey, we'll come back to this tax problem. Let's come back to this tax problem tomorrow. Why don't we go ahead and go out and have a nice walk on the beach, or let's go have dinner now. To just physically remove the person from the environment that's triggering that loop.
Got it. Thank you. We could have a conversation for another hour. I am certain of that. The wealth of information and insight and wisdom the two of you bring is really, truly wonderful. I know our audience has benefited and probably has more questions. So from us at the Davis Phinney Foundation, we are incredibly grateful for those of you who have joined us today, and for Dr. Pontone, Dr. Hamilton, for being here, as well to Amneal and to CND Life Sciences for supporting our work in this profound way. Thank you for joining us, and we look forward to seeing the two of you and all of you in the audience again shortly. Take care, everybody.